Good morning, everyone. Thanks a lot for spending a little bit of your Saturday with us, and thanks to Mark and Tamar for a great program. I'm going to be talking about shoulder replacements today and the technological advances that we have to try to make this a better procedure for our patients, and there is a lot happening in the area of shoulder arthroplasty. We've talked a little bit about the anatomy in general, and Dr. Green touched on the articular cartilage. This is a highly specialized connective tissue, a well-organized layered structure made primarily actually of water and these proteins, hyaluronic acid and chondroitin sulfate, and also living chondrocytes. And the purpose of the articular cartilage in any joint, including the shoulder, is to provide a smooth lubricating layer for friction-free motion as we use our shoulders day in, day out over a lifetime. Articular cartilage in a patient with arthritis is characterized first by cracking and fissuring of the cartilage and then eventually wearing away of the cartilage, as Dr. Green pointed out. And it really is when that bone is exposed underneath and you start to get bone-on-bone articulation that you develop pain, stiffness, mechanical symptoms, and dysfunction. The shoulder is a little bit different than other joints in the body in that it is less constrained. It's unstable by design. That's what allows us to have more motion at the shoulder than any other joint in the body, but it also means that it's relatively unstable and we need other structures to provide stability to the shoulder, namely the rotator cuff. So we think about the rotator cuff in terms of its ability to move our arms in space, but more importantly, the rotator cuff serves like reins on the horse to draw the ball into the socket and maintain stability to create a fixed fulcrum for motion. And we have to keep this delicate stability in mind when we're thinking of performing a shoulder replacement. So taking a step back and looking at the bony architecture of the proximal humerus, or the upper part of the humerus, the theme here is that there is tremendous variation from patient to patient. So first, looking at the ball, we can look at the ball here in terms of both its thickness and also its radius or diameter. And there have been a lot of studies looking at variation, and there is tremendous variability, ranging anywhere from 15 to 30 millimeters, depending on which patient you're treating. If you then look at the angle that the ball makes with the shaft, looking from the front, that's called the inclination. And the inclination also varies tremendously. And finally, when you look down on the ball from the bird's eye view, you see that the ball actually faces towards the back of the patient in most patients. This is called retroversion. And again, tremendous variation from patient to patient. This retroversion can vary anywhere from 0 to 60 degrees depending on what study you look at. So this is, again, important when we talk about shoulder replacement, because rather than taking a uniform approach to each and every patient, we want to try to recreate the patient's individual anatomy in order to provide the best outcome. So this is what a X-ray of a patient with shoulder arthritis looks like, some characteristic findings. The left panel is looking from the front. Here's the ball and socket joint, and in this particular patient, of course, the defining characteristic of arthritis, where you get narrowing of the space between ball and socket. But this patient, who has lived with arthritis for many years, has started to develop flattening of the humeral head, and also osteophytes that start to extrude out the top and bottom of the joint, called a goat-speared osteophyte, that can obscure their normal anatomy. And then on the right panel, you see that this patient has other characteristic findings in the shoulder. In routine shoulder osteoarthritis, it's not just a bony condition, it's also characterized by a bit of soft tissue instability where the ball starts to drift out the back, and when that ball is riding out towards the back of the socket for a prolonged period of time, that patient can develop a deformity over many years. And in this patient, they not only have that slippage out the back, but they also have a socket that's beginning to wear away in the back and increased retroversion of the socket itself. And again, we have to keep this deformity in mind. This is how the surgery is done in an animation. So we first have to define the neck and cut the neck to remove the ball. We can use cutting guides as seen here, but to be honest, this portion of the procedure is usually done freehand according to the surgeon's judgment. You then prepare the inside of the canal with first a canal finder and then a series of reamers or sounders to define the maximum internal diameter of the canal. And then when you're done, you use broaches that look like the stem to prepare the inside of the canal for eventual stem insertion. You then take the ball that you removed and you compare it to trial humeral heads from the tray and choose a humeral head that reflects that thickness and diameter of the patient's normal anatomy. And Once you've selected the right head, you take that head, bring it over to the humerus and assemble it onto the stem, and then you can dial in the offset, which is the difference between the center of the head and the center of the shaft. And then once you're done with the humeral side, you can take the trial out, and then you can prepare to put the final stem in. And the final stem in this day and age is typically pressed in or squeezed into place, and the final ball is then assembled with the proper offset size and thickness. And that's what the final humeral side looks like. On the glenoid side, one of the challenging parts of resurfacing the socket is exposure on that first top left panel. Once you have adequate exposure, the next key step is placing this center pin. And that center pin has to be placed at the precise location and with the correct angulation, because it's going to define the rest of the procedure on the socket side. You're going to ream the surface of the socket to remove the arthritic surface. You're then going to drill a pilot hole on the bottom left. In the middle left, you're then going to drill holes in the periphery to insert a plastic pegged glenoid component, and then cement in the final piece. When we do these various steps to the operation, we have certain fundamental goals in mind. Number one, as I've mentioned, you want to restore the patient's normal anatomy, how they were born. And number two, you want to account for that instability and restore normal stability to the joint to center the socket, the ball on the socket. In order to do this, we have to, again, define the normal anatomy if we can. We have to look at where the anatomic neck is, the junction between ball and shaft, and then look at those various angles that the patient has to recreate those angles with metal and plastic. On the socket side, again, we have to determine deformity, and then we have to try to correct this deformity either by reaming one part of the socket more than another, called eccentric reaming, or using a wedge-shaped plastic piece to account for bony deficiencies. So we can take that first x-ray that we looked at, a flattened head, obliterated joint space, and large osteophytes, and using metal stem and ball recreate the patient's normal anatomy. On the socket side, again, we can take this patient whose ball was slipping out the back and the glenoid socket was worn out the back, and use a wedge-shaped design and some eccentric reaming in order to center the ball relative to the plastic component to restore that stability. But this can be a challenging operation, and there is a clear learning curve. So surprisingly, what we find in these studies that have looked at how commonly these procedures are done, up to 3/4 of the shoulder replacements that are done in the US are done either by general orthopedic surgeons or surgeons that perform less than 5 procedures per year. And multiple studies have shown a direct correlation between how many of these procedures you perform and patient outcomes, whether you're talking about infection rates, surgical time, blood loss, survivorship of the implants, or ultimate patient function. So we have to find a way to make this procedure reproducible in anyone's hands, and technology has allowed us to do this. So traditionally, we've only had access to these two-dimensional CAT scans. We would choose an illustrative slice that represents the patient's anatomy, and then do some measurements on the left panel, which shows that in this patient, they're facing the back about 27 degrees. And then on the right, we do some surgical planning by hand. We talk about how much correction we want to perform, how much bone we want to take, and then how much bone is left over for insertion of the plastic piece. But there's a lot of judgment and opportunity for error with this approach. And Dr. Iannotti, one of the preeminent shoulder surgeons from the Cleveland Clinic, looked at how much error there is when we do it in this way, and he looked at how good we are at, number one, defining version and bone loss, and then number two, how good are we in then bringing this information to the OR to put the glenoid component in with optimal positioning. And what he found is that we're actually not that great at it in certain cases. With moderate to severe glenoid deformity, traditional surgical techniques are not necessarily accurate and reproducible in everyone's hands, so there must be a better way. And three-dimensional imaging has helped us to a certain degree. So depending on what slice you look at on a CAT scan, the shape of the glenoid will change. 3D imaging on the right might be better in allowing us to get a better overall perspective on the patient's anatomy and deformity. And we can take this information and put it into software and then begin to manipulate the information to plan the procedure. This software tells us what the angulation is objectively. And we can manipulate the images in 3 dimensions to look at subluxation, how much that ball is beginning to ride out the back of the socket. Once we have that information, we can then perform the procedure on the computer ahead of time. We can choose different size glenoid components. We can rotate the component to fit the patient's socket better. We can decide how to angulate the component up, down, front, back. and then how much bone to take in order to be able to seat that component flush with the patient's own bone. When we're done with this, we can then look at our finished product and determine how good we were at establishing our goals. We can manipulate the humeral side and decide, again, where we're going to cut the anatomic neck, how we're going to insert the humeral stem, what size ball we're going to choose, again, to recreate the patient's own anatomy, and then how we're going to orient that ball to choose proper offset, as we see here. So here's the finished product. This is the replacement done sort of in virtual reality, so to speak. And we can see here how well we did in recreating the patient's own anatomy and how well we did in recreating stability, centering the ball on the socket. So this is an incredibly powerful tool, and it's even more powerful with a slightly different type of replacement that we perform. The reverse arthroplasty is a procedure where, unlike an anatomic replacement, we put the ball where the socket used to be, and we put the socket where the ball is normally. And it can be very effective in people with a particular type of arthritis, where they have not only the routine arthritis, but also an irreparable cuff tear. And reverse arthroplasty can also be done in patients who need revision surgery. And pre-surgical planning is incredibly powerful with reverse arthroplasty, because you can see here, in this procedure, we use bone graft, as seen in the orange. And the pre-surgical planning software allows us to choose the right size of bone graft and positioning of bone graft. And then it allows us to choose the implants, the metal and plastic, and position them properly, as we did with an anatomic replacement. In contrast to the anatomic replacement, doing the reverse in this software allows us then to take the arm through an arc of motion and determine impingement-free motion. And that's very important. How much can we move this arm in the software and then in the patient before the prosthetic implants contact the patient's bone? We want to avoid impingement because that'll, of course, improve their function, but it'll also improve the durability of the replacements themselves. And so this software helps us do that. And the next challenge, once we've spent a lot of time and deliberation planning the procedure, we then have to translate the procedure to the operating room, because at the end of the day, the effectiveness of pre-surgical planning is only as good as we can replicate it in the OR. And patient-specific instrumentation has allowed us to do that. So we take the pre-surgical plan that we've developed. The manufacturer then uses three-dimensional printing to print these cutting guides. And these cutting guides and drill guides contour to the patient's own anatomy. You can see in the top panel, here's a drill guide that has feet that are contoured to the edges of the joint, and it seats perfectly on the socket and allows us to place that guide pin with precision. And then there are some additional guides that can help us determine exactly how much bone to remove. And then, in addition, in the case of reverse arthroplasty, the trajectory for our screws that help us get enhanced fixation of the implants. Well, the same group out of the Cleveland Clinic then asked, are these technologies effective? Is three-dimensional planning effective in improving the location of our guide pin and the angulation of our guide pin? And does patient-specific instrumentation have anything to add? And what they found, number one, as the first study pointed out, there's tremendous variation when you don't have access to these technologies. When you add in pre-surgical planning, the angle of the guide pin improves anywhere from 3 to 4 degrees. And then when you further use patient-specific instrumentation, that improved angle goes up to 8 to 11 degrees. So there's a meaningful impact on precision using these technologies. There's some future directions, and all of these things are efforts to, again, precisely bring that pre-surgical plan to the operating room. With PSI, you're using these 3D printed cutting guides and drill guides. With computer navigation on these left panels, instead of using cutting guides, you're bringing a computer into the OR, and the surgical instruments are connected to the computer wirelessly, and the surgeon can check the precision of their drilling and cutting in real time to make sure that they're replicating their plan. And then there's the Mako Robot, which is used presently with hip and knee replacement. The Mako Robot is a haptic robot, and what that basically means is that the surgeon controls the robotic arm, but based on the pre-surgical plan, the robotic arm will not let the surgeon make an error compared to what they intended to do. And it has shown to improve component positioning in hip replacement in particular and partial knee replacement. So there's opportunity for an application in the shoulder, and it's currently being investigated. So in summary, successful shoulder replacement requires correction of deformity that's accrued over years, and restoration of normal anatomy. 3D planning allows us to precisely plan to accomplish these goals, and patient-specific instrumentation allows more precision when we bring this surgical plan to the operating room. But the truth of the matter is, this technology is most useful only in these complicated cases with severe deformity. It hasn't really shown to be effective or necessary in a more basic case of routine arthritis, and in fact, the cost associated with these technologies may not be justified. And at the end of the day, whether it's a basic shoulder replacement or a complex revision case, there is no replacement for surgeon experience and clinical judgment. So, thanks very much. Appreciate it.